considering other persons. Oh, I'm sorry, something happened here. Okay. When you see data from older persons aged 70 plus years, you see that cardiovascular diseases remain as the leading cause of death, but lower respiratory tract infections and falls rises and, and becomes relevant conditions to be addressed, uh, together with hypertension and diabetes, Alzheimer's disease, Parkinson's disease. When, oh, I'm sorry. Okay, here we go. When you look to the 80 plus population, the same pattern is repeated. However, look here, respiratory infections become a very important cause of mortality, as well as falls in Alzheimer's disease and Parkinson's disease. So these conditions must be in the center of our care planning for older persons. But before discussing clinical conditions, let's remember what we addressed yesterday. To keep in mind these important concepts that we are talking about, an integrated community person-centered care for older people. So, and that all we'll talk about today is about diagnosing and caring for people in the primary healthcare setting. And remember that we have to assess the older we have to assess older persons beyond clinical conditions, and using comprehensive geriatric assessment or a simple tool like the clinical frailty scale, we can categorize older persons into robust, preserved, homeostatic reserve group, pre-frail, slightly reduced homeostatic reserve category, and frail individuals. And these different phenotypes inferring physiological reserve and vulnerability are very important when we are planning how to care for a person, an individual person. So a robust individual is managing well and usually respond well to stressors and recover fast, and almost all time recovers, fully recovers for after a clinical event. A mild frailty patient usually face more problems and much more problem to recover from external stressor, and most times are not able to fully recover. And frail individuals not only are more vulnerable to these different kind of stressors, but usually become more frail and more dependent after one episode. And a stressor can be a medication uh, or a treatment or even a diagnostic test or a procedure. So we have to keep this in mind. And most importantly, usually we deliver disease-based healthcare, and all the patients tend to present with several different diseases. And I'm sorry, here. Our our still standing medical paradigm is to individually tackle each one of these conditions, sometimes uh, by different doctors who will care for, endocrinologists will care for diabetes and dyslipidemia. A cardiologist will manage hypertension and ischemic heart disease, and so. And you have to change it because if a patient has three diseases and has three different doctors who are using three different guidelines to treat the patient, maybe we'll have problems here because few or none comprehensive assessment guidance would be provided or will be part of a caring plan for all the people. So we have to change to a person-centered healthcare, as I I said yesterday, because one individual will present with several concomitant diseases, and we have to address it altogether because this is one patient and not one disease for each doctor to be uh, to be cared. So when we are planning to care for an older patient, we have to consider function and abilities. We have to consider mental health and cognition because it is important when regarding treatment adherence. We have to know if this patient has support networks and needs, what are the patient needs. And of course, we have to assess deeply the disease severity and look carefully for all the comorbidities that can interfere not only with treatment, one condition's treatment, but can negatively impose more complications for a second disease. So, addressing older persons, addressing different diseases in older persons requires a broader look, a comprehensive look to vulnerability, first of all. So, before addressing this vulnerability, these possible vulnerability states, we would be able to weigh possible benefits and possible risks here. So for each one of the vulnerability categories, I'll be able to, to properly weight this benefit risk ratio to plan a proper care, a proportional care. So after assessing the patient not only for disease severity, uh, but for vulnerability status and function and abilities and social networks, support networks, I'll be able to choose the best treatment for my patient. Of course, always based on scientific evidence. So translating scientific evidence and treatment efficacy to an individual scenario where I'm able to weigh possible risks and understand that the more vulnerable a patient is, the greater the risk to an adverse event is. I'll be able to choose properly, to choose the best action plan. And the action plan could be a treatment, a blood transfusion, a hospital admission. But sometimes the best way to care for a patient is watchful waiting, is observing and wait for what will happen if this weight between possible benefits and risk scale tends to one side instead another side. So considering this, we'll be able to deliver proper care, right care for a patient. And sometimes the best course of action is to do what some call nothing. But nothing is not nothing. Sometimes nothing is the best approach. Nothing is a lot, because nothing involves individual decision, involves positive communication, patient education, involves a care plan, not only medical care, but a network of care, sometimes including rehabilitation treatments, sometimes including wound dressings and several other conducts to proper care for this patient. And sometimes this called nothing is the best option to do no harm to a patient. If a patient is too vulnerable for a treatment, sometimes the best way to act is to do this nothing, to do no harm, to deliver symptom-driven actions, and sometimes palliative care and end-of-life care. Of course, this is not for every older patient. This is for vulnerable older patients, and sometimes for a robust or pre-frail patient with a very severe or end-stage disease. Again, we have to weigh potential benefits and risks. We have to put these variables in this scale and decide and to choose what is best for my patient. And again, sometimes this called nothing is the best approach. So keep it in mind. Here are an illustration showing us that we have to go beyond treatment for specific diseases like hypertension or diabetes or preventing stroke, secondary prevention for stroke. We have to plan interventions aimed at preventing or reversing frailty in patients with any clinical conditions. And we have to think about it always when you are planning, when you're developing a treatment plan to care for an older adult. We have to think about interventions for frailty among older adults with cancer or diabetes or dementia or cardiovascular disease whatsoever. We have to think how we'll manage this concomitant problem that sometimes poses a huge burden over a patient, even greater than the disease itself. So we have to remember, if possible, to refer patients for physical rehabilitation. We have to think about and assess and consider cognitive impairment during our treatment planning. We have to address pharmacological issues, as we'll see in the next section. We have to check for treatment interactions, for potentially inappropriate treatments for vulnerable older patients. We have to consider nutritional guidance. We have to consider nutritional vulnerabilities that can be reversed. We have to consider psychological issues that can intervene with other treatments. So, if a patient is robust, let's give them guidance on how to keep like this, how to maintain the robust status. If a patient is pre-frail, the yellow subgroup I showed you a few slides back, let's consider this like secondary prevention. Let's prevent the progression from pre-frail to frail status. And if a patient already is frail, let's deliver conducts to improve quality of life. Let's put quality of life as the main outcome to be monitored. So, any questions or comments about this first section, please feel free to ask. Just raise your hand and open your mic, unmute, please.
If anyone has a question, you must raise your hands, please.
Okay, let's go on. And don't forget, you can put your question in the chat box, and it's going to be my pleasure to answer it later. So this is a very important topic today. How to prescribe properly. How is the best prescribing approach in older people? Because as you can see here, this is a very prevalent situation, as an older person tends to have several comorbidities at the same time. Here is data showing us that with age comes wisdom and prescriptions. Sure that have taken prescribed medicines in the last week in England, one or two medicines in this light green, 3 to 4 orange or yellowish, and 5+ medicines in dark blue. Here you can see that the older the patient is, the greater is the number of medications a patient is taking. You can see here that patients over 65 years tend to take several concomitant medicines. And if you carefully look at this bar here, you will see that more than 20% of patients over 65 years to 74 years are taking 5+ medications. 75 to 84 years, more than 30% are taking more than 5 medications. And in the very old subgroup, it's almost half patients using 5+ medicines. So polypharmacy, defined as the concomitant use of 5+ medicines, are very prevalent among older adults, especially in the older ones. So this is when medicines interactions happens. This is the scenario where we have more vulnerable patients, and this is the scenario where we have a high incidence of drug-related events. So we have always to keep this in mind. We have a situation where medications are needed, are required. This is not a simple matter of number of medications. Several medications are needed and must be prescribed. However, we have to consider this huge number of medications as a potential problem, and we have to take a careful look at this. In Canada, 2 out of 3 Canadians over the age of 65 take at least 5 different prescription medications. 2 out of 3. That's a lot. But we know why this happens. Because older persons tends to have several concomitant diseases. But let's take a closer look in this subgroup of 2 out of 3. 66% of patients take at least 5 different prescriptions. But if you take a deeper look into this subgroup, we'll see that 27% of them takes more than 10 medications. 20% of seniors age 65 to 74 years, 74 years take at least 10 medications. 32% of seniors age 75 to 84 take at least 10 medications, and almost 40% of seniors age 85 plus take at least 10 medications. And that's a lot. More statistics here. Polypharmacy, polypharmacy is a problem, but we have to look at it with more information to be considered. The oldest subgroup is responsible for 40% of prescribed medications, all prescribed medications. Polypharmacy occurs in more than 35% of all the patients. And if you consider over-the-counter medications and supplements, 67% of older patients are under polypharmacy. And this is a well-known risk factor for adverse drug events. 88% of adverse drug events are preventable. 88% of preventable hospitalizations, meaning hospitalizations caused by adverse drug events, can be preventable in 88% of the cases. 88% risk of adverse drug event. 88% is almost a magic number here. And we'll talk about as well as about potentially inappropriate medications. 33% of medications on geriatric medication list, meaning that 33% of medicines prescribed for older persons are potentially inappropriate, according to important prescribing in older persons tools, as we'll see in the next slides. Here's a study assessing hospitalizations caused by adverse drug reactions in patients, in any aged patients. This is a meta-analysis of observational studies. Here is the total number of the total number and percentage of hospitalizations caused by adverse drug reactions. Something around 5% of all of all hospitalizations are caused by medications. As an example, an hypoglycemia event secondary to insulin use, or bleeding in a patient using warfarin to prevent stroke in a patient with atrial fibrillation. But if we look to different subgroups, vulnerability subgroups here, non-elderly patients and elderly patients, you'll see that among younger adults, 4% of all medical hospitalizations are caused by adverse drug reactions. However, this number increases a lot, a fourfold increase in hospitalizations caused by adverse drug reactions, because older persons use more medication and are more vulnerable to iatrogenic events. There's 16%, almost 17% of all medical hospitalizations among elderly patients are caused by adverse drug reactions. And most important, 88% are preventable with simple measures, simple procedures, and uh, care, proper prescribing in all the places. Here are the frequent culprits. The NSAIDs, including aspirin, are responsible for almost 30% of all ADR admissions, followed by diuretics, warfarin, ACE inhibitors. Here you can read hyperkalemia. Here you can read bleeding. Here you can read hypokalemia and hyponatremia, bradycardia, and here digoxin intoxication. And so those are the culprits. These are the culprits, most frequent culprits. And why this happens? Let's take a look in some theoretical aspects that can be associated to this greater risk for adverse events, serious adverse events. During the aging process, the human experiences several physiological changes that may influence how a medicine is absorbed, distributed, excreted by the human body. In older patients, the absorption of medications absorption can be reduced because saliva secretion is reduced, because the gastric pH is increased, gastric and acid secretion is decreased, gastric surface area is decreased, and most importantly, the distribution of medicines are affected by reduced hepatic blood flow, increased by the increment of adipose tissue. Fat is an important factor when medicine distribution is being discussed. In an older patient, it is expected that diazepam, for an example, be much more diazepam has a much broader distribution in an older body because of the increase in adipose tissue, and several other changes affecting how a medication is excreted by the kidneys And all this together results in increased medicine half-life, increased serum concentration, and increased risk for drug interactions. So this imposes more vulnerability to iatrogenic events, to serious adverse drug reactions. Here is a mnemonic to help doctors to optimize medication safety for older adults. Let's take a closer look. D, discuss goals of care and what matters most to the patient. Include patients and caregivers in the prescribing discussions to ensure decisions focus on goals of care. Remember, goals of care must be addressed according to a patient function status, a patient vulnerability status. Another step, review medications. Encourage patients to bring all prescribed and over-the-counter medications to their appointment, because they usually don't tell us about over-the-counter medications and medications prescribed by neighbors. Review medications on an ongoing basis and when clinical conditions or goals of care change. Discontinue potentially unnecessary drugs. A medication could be useful for a symptom or a condition that no longer exists. So we can discontinue this unnecessary drug. Consider drug side effects as a potential cause for a new symptom. Some dare to say that a new symptom in an older patient is caused by a medication until proved otherwise. Consider non-pharmacological options especially for pain control and for hypertension and diabetes. Change medications for safer alternatives when possible, when available. We know sometimes a medicine can be included in potentially inappropriate medications list. However, that is the only option, the only available option we have. So we will prescribe this drug. Remember, these lists are not a forbidden list. This is an alarming list. When you have to use one of these medications, we just have to pose more attention and additional monitoring. It's not forbidden to prescribe, but especially when this specific medication is the only option we have, or it is among the few options we have. Lower the dose always possible. Identify possible prescribing cascades. Determine when the medication was started and why. Any medication, I'm sorry, a medication, a medicine in a patient's prescribing should have an indication, a proper indication pointed in the list of problems. If you don't find the proper indication listed in a patient chart, think over it. Try to understand if that medication is really needed. And if you don't find any evidence that a medication is needed, you can think about deprescribing to avoid prescribing cascades, as I'll show you in the next slides. Going on the letter U, use tools and frameworks for proper prescribing in older adults. Identify drugs from the inappropriate prescribing tools, including Beer's criteria or STOP criteria. I'll show you later. Use the STOP frail list when the individual is extremely frail and approaching the end of life. Consider whether the new or existing medical condition could be the result of a prescribing cascade and ask, is a new drug being prescribed to manage a side effect from another prescribed drug? Could the initial drug be replaced with a safer drug, or could the dose be reduced? Does the patient need the first drug, or could this drug be stopped? These are very important questions to avoid a prescribing cascade. Okay? Pay attention to all the people who are receiving so-called good drugs with narrow therapeutic windows that might no longer be needed or for whom dose reduction might be beneficial. One example here is digoxin or for warfarin, anticonvulsant medication. G4, geriatric medicine approach. Geriatricians carefully consider how multiple medical problems, frailty, cognitive impairment, and limited life expectancy, reduced medication benefit, increase adverse events, or at least increase the risk for adverse events, or interfere with medication adherence. So again, comprehensive assessments are required to understand not only risks, but if potential benefits are reduced. And as finishing our drugs mnemonic asks to stop the medications, consider the algorithm created by Scott or the good palliative geriatric practice algorithm to guide the prescribing. There's a very good website guiding the prescribing as well. That is the deprescribing.org. O-R-G. So I mentioned tools and frameworks to avoid potentially inappropriate medications for older people. So here are some examples. The first one is the drug burden index that considers anticholinergic risks and hypnotics and sedative medications as the main cause of serious adverse reactions in older patients. But this is this is not a very easy to apply criteria. So I'll present you this top criteria and the Beers criteria to be implemented in clinical practice scenarios, in different clinical practice scenarios, especially in outpatient clinics and primary care. The first one is the stop-start criteria. Stop for screening tool of older people's potentially inappropriate prescriptions, and start for screening tool to alert doctors to write treatments. These tools are very important to prevent inappropriate drug use and to prevent underuse as well. Underuse is also an important problem. So we have to find a balance between preventing inappropriate use and preventing underuse. We have to be careful to not fall into a trap, a mental cognitive trap called less is always better. Less is only better when more is not good. Sometimes more is good. But when we're looking to a prescription for an older adult, we have to consider both scenarios. When less is better and when more is better. Sometimes we have an unuseful medication prescribed, and we also see that an important medication is missing. This is about proper prescription. This is not about numbers of medications. I think it's important to highlight. Cool. Here. Can you see the stop-start document on the screen?
Yes, we can.
Here is the document. I'll just quickly show you how this document goes.
Excuse me, Hanato, it is still, it's this slide, not a document.
Okay. Same problem as yesterday. I think you can see now.
Yes, we can.
Okay, here's the stop-start toolkit, support and medication review. Let's start with an example. Here. Chapter 1, gastrointestinal system. What should be stopped? or prevented. Again, this is not prohibited, but we have to prescribe with caution. Metoclopramide. Do not prescribe metoclopramide in patients with Parkinsonism or Parkinson's disease because metoclopramide imposes risk of exacerbating symptoms. Do not prescribe metoclopramide after maximum treatment time of 5 days. PPI for uncomplicated peptic ulcer disease at full therapeutic dosage after 1-2 months. If healed, offer low dose maintenance treatment, possibly on an as required basis. This is the stop criteria for gastrointestinal system. Let's take a look in the start. Gastrointestinal system start. PPIs. PPIs are effective medication that should be prescribed at full dose and long-term use with severe grade esophagitis or esophageal stricture requiring dilation for patients on medication with risk of gastric bleeding, like antiplatelets, corticosteroids, and NSAIDs. Let's take a look to the cardiovascular system stop, the digoxin. Avoid prescribing this medication for heart failure with normal systolic ventricular function, preserved ventricular function. Avoid this medication for left systolic ventricular dysfunction, where key interventions had not previously been tried, like ACE inhibitors. Avoid thiazide diuretic medication with current significant hypokalemia or recent concurrent gout episode. Avoid lipodiuretic as treatment for hypertension, for dependent angioedema without clinical biochemical evidence or radiological evidence of heart failure, liver failure, nephrotic syndrome, or renal failure. This is basic concepts, but that we have to remember on a daily basis because these medications can be effective and well indicated in some circumstances. Here, let's start cardiovascular system criteria. Antihypertensive therapy is needed where systolic blood pressure consistently above 160 millimeters of mercury. If a patient is diabetic, with systolic blood pressure above 140. Beta blocker or calcium channel blockers for patients experiencing stable angina. ACE inhibitor for patients with systolic heart failure and or documented coronary artery disease. So these are examples about when we have to use the stop approach or the start approach. Here are other examples, but I won't read it again as I already showed you. And start criteria being applied here. Warfarin in chronic atrial fibrillation. Elderly patient patients, older patients, are at the higher risk for thromboembolic events. So unless there is a major risk of bleeding or a major contraindication, warfarin should be prescribed for patients with chronic atrial fibrillation. Of course, again, we have to consider vulnerability first, as I showed you earlier. Now I'll show you a practical example of what prescribing Cascade is. Here we have an older person experiencing a new symptom. And with this new symptom comes a new prescription. This new prescription imposed an adverse drug reaction. And this adverse drug reaction was treated using a second drug. This second drug used, prescribed to treat an ADR, caused a second ADR. And then a third drug is prescribed to treat the ADR, the new ADR. And this third drug caused a new symptom. So this is a vicious circle that must be broken. Here, another person presents with nausea. I prescribe metoclopramide. Because of metoclopramide, this patient presents with tremors and muscle stiffness because anti-dopaminergic effects of metoclopramide. Tremors and muscle stiffness can be interpreted as Parkinsonism or Parkinson's disease. And maybe some will prescribe levodopa to treat these symptoms. Levodopa can cause adverse reactions like more nausea or even abdominal pain. This patient in particular presented with abdominal pain after taking levodopa. And the abdominal pain, and for the abdominal pain, a doctor prescribed an opioid. And the opioid caused nausea. And then the doctor increases metoclopramide dose. And patient then presents with confusion, delirium. And for this acute confusion state, another doctor prescribed an antipsychotic medication. This antipsychotic medication caused tremors, muscle stiffness. And then another doctor increases the levodopa. And the levodopa worsens nausea. This is a classic example of a prescribing cascade. As the patient presented with worsening nausea, the metoclopramide dose was incremented, and the patient presented with worsening delirium. delirium with agitation, and agitation led to an increasing in the antipsychotic and psychotics dose. And then patient presented with postural instability, and the patient fell and fractured a bone. Yeah, this is a very extreme example, but I can say that I saw quite similar cases during my years as a geriatrician, especially because I'm a hospitalist geriatrician. So, how can we avoid a prescribing cascade? What can we do to prevent a dramatic event? First of all, choose the safer, available, and affordable medication. If you do not have a second option, start the medication in the lower possible dose. And always consider potential risks and benefits before prescribing. If I choose the best option or the safer dose, maybe I'll avoid a adverse drug reaction. But sometimes an ADR occurs even in lower doses or with the safer option, especially in vulnerable patients. So it is important to educate the patient for possible adverse reactions, to encourage the patient to seek help if an adverse event occurs. So the patient will seek help earlier before serious complications occur. And be available to reassess this prescription and to stop the medication or lower the dose. If you do, you will prevent the prescription of a second drug to treat the first ADR. You won't prescribe a medication to treat the side effect. Reduce dose, de-prescribe instead of prescribing a second medication. Always remember that a new symptom can be caused by a new prescription or an over-the-counter medication. Monitoring is very important when you prescribe a new medication. If I properly do it, I'll avoid a second ADR, a third drug, and I'll stop the wheel. I'll stop this vicious circle of prescribing cascade, of the prescribing cascade. Here is a happier vicious circle, a positive vicious circle. Assess patient, define overall treatment goals. Always keep an updated list of medications. Educate patients to have an updated list of medications. Encourage patients to bring all prescribed and unprescribed medications to an appointment. identify inappropriate medicines, but never forget to assess underuse as well. Assess each medicine for specific risks and benefits in patient context. Remember, we have to check vulnerability using the clinical frailty scale or a comprehensive geriatric assessment or assessing intrinsic capacity losses. Stop or reduce medication dose if needed. Communicate actions with prescriber. Monitor and adjust as appropriate, and be available to reassess. Please, you can put your questions or comments for the session.
Once again, any participant wishing to ask questions, you must raise your hands, please.
Here I have a question in the chat box, in the key Q&A chat box from Pedro Pons. Pedro is a gerontogeriatric in Guyana, where has been treated in the previous conference yesterday. I'm sorry, he's saying that it was an interesting conference yesterday. And I want to know your suggestion, opinion of the value to start at least, if not possible, in primary prevention, at least to address more the secondary prevention, which could have an important decrease in morbidity, mortality, disability, among others. How do you see the contribution addressing properly the chronic non-communicable diseases at early ages, such as from 40 years or even 50, to decrease, avoid different levels of deterioration in the future elderlies in our country? Thank you, Dr. Pedro. This is a very interesting comment and question. As we start talking today, we have to properly address common conditions and treat it accordingly, as we'll see in more details in the sequence. Because, as I said, this is not just about avoiding prescriptions, but there are several scenarios, clinical scenarios, where we have to prescribe medications to prevent cardiovascular events, to prevent a stroke. And secondary prevention is the clinical scenario where we have the greater benefit of treatments. So even when a patient is vulnerable, but still keeps their functional ability, it is, at least in part, we have to think about preventing future events. We have to prescribe medications to avoid a second event, because a second stroke may impose several other limitations and worsen quality of life. So this is a very important question, Dr. Pedro. And regarding the assessment of younger patients, I agree with you. We have to to screen for risk factors the earlier as possible after the 30s, 40s. Especially we have to screen for hypertension, obesity, and high blood sugar levels because these three conditions are associated with a higher incidence of important and severe conditions. So I agree with you. We have to take a closer look and care for younger patients as well to prevent future events, prevent future disabilities. And in such cases, non-pharmacological treatments have a great importance. Education, health education has an important role here. I hope I properly answered your question, Dr. Pedro. Thank you so much. So we can have a 10-minute break now, and we'll resume at 10:30. Okay? See you in 10, people. Okay, let's resume. Let's talk about now the most common clinical conditions in older persons. Here are the 10 common chronic conditions for adults 65 plus years. 80% of older persons have at least one chronic condition, and 68% of them have two or more chronic conditions. Hypertension is the most prevalent condition. As I showed you yesterday, the numbers go from 58%, but if we consider the older the older subgroups, it can reach higher, even higher prevalence rates, 75% of 75 plus older person subgroups have hypertension. High cholesterol is found, it can be found in 47% of older adults. Arthritis, 31%, ischemic coronary heart disease, almost 30%, diabetes, 27%, much more prevalent than in younger patients. Chronic kidney disease, heart failure, depression, Alzheimer's disease, and dementia, in more than 10% of patients, reaching 30% in 85 plus older adults, and chronic obstructive pulmonary disease, more than 10% as well. So let's talk about the most common conditions, not the 10 common, but we'll talk about now about hypertension, diabetes, dementia, and falls and fractures that are very prevalent and important conditions. Let's start with hypertension, as it is the most prevalent and it is associated with several problems, from coronary disease to hypertensive heart failure, cardiomyopathy, and chronic kidney disease, and other complications. Here I show you the hearts in the Americas program. That is an initiative of the countries led by the ministries of health, with the participation of local actors, with the technical cooperation of PAHO, which seeks to integrate smoothly and progressively to already existing health delivery services to promote the adoption of global best practices in the prevention and control of cardiovascular diseases, and to improve the performance of the services through better control of high blood pressure and the promotion of secondary prevention with emphasis on the primary health care. The heart programs tells us that by 2025, the heart's model will be the model for the cardiovascular disease risk management, including hypertension, diabetes, and dyslipidemia in primary health care in the Americas. Heart is being implemented and expanded in 24 countries of the region to include And this is the case of Guyana. Well, as previously stated, hypertension is a common problem in elderly subjects, reaching a prevalence as high as 60 to 8% in the older subgroups. As an example, in the United States, hypertension was observed in 67% of adults aged 60 to 69 years, who were participants in the National Health and Nutrition Examination Survey. In here, these charts demonstrate how blood pressure increases with age. Systolic blood pressure increases with age, and diastolic blood pressure decreases with age as a consequence of the aging of the cardiovascular system aging, especially arterial stiffness. Actually, here it's possible to see that systolic blood pressure rises while DBP decreases along the time, forming this gap that is called post pressure. Today, we know post pressure is an accurate predictive factor for cardiovascular diseases, more accurate than systolic blood pressure, isolated systolic blood pressure. And however, until few decades ago, in the 90s, most doctors believed it was a physiological response to arterial stiffness in order to maintain organs blood perfusion. And still today, some doctors are afraid about treating hypertension in older patients. This is a worldwide phenomenon that is less common today, but it still exists. Here, several studies kept showing that both systolic and diastolic blood pressure increases were associated to greater risk for cardiovascular mortality. In 2002, there's a study published in the Lancet in 2002, comprised data from more than 1 million individual data from more than 1 million persons in the United States. And it was possible to conclude that at each 20 millimeters of mercury increase in blood pressure, they double the absolute risk to die from ischemic heart disease. And the risk pattern, the increased risk pattern, is the same for older adults, independently of the age subgroup, for both systolic and diastolic blood pressure. The same pattern here for stroke mortality. Each 20 millimeters of mercury increase in blood pressure, the double is the absolute risk of dying from a stroke episode. So, regardless of age, hypertension is a significant cardiovascular risk factor. 49% of all acute myocardial infarctions occur because hypertension exists. This is what we call attributable risk. Even more alarmingly, if hypertension could be extinguished from the world, 62% of all strokes would be prevented. Hypertension is responsible for 62% of all strokes. If any doubt about the relevance of hypertension as a risk factor in older persons was still remaining, several consecutive clinical trials were published in the 90s, put this previous concept that hypertension was a physiological response, put this concept behind for good. The SHAP trial, here represented, showed not only a reduction for stroke incidents, a 40% decrease in stroke incidents, but showed a 25% decrease in the incidence of cardiovascular diseases. Here, I'm sorry, cardiovascular health, cardiovascular diseases. Yes, that's it. And after that, several other studies kept showing the same result, same pattern of result. Yet, considering treating older adults aged 80 years or more, and the feeling, the fear of causing harm was still there. So in 2008, the results from the Harvard trial was published. The Harvard trial included only 80 plus years patients to be treated for hypertension or not to be treated. They were randomized to receive hypertension treatment or placebo. And the results were very clear, showing significant reduction in the incidence of death from cardiovascular causes, death from stroke, and decreasing in more than 50% the incidence of heart failure. So the paradigm was shifted even for 80 plus patients. That being said, hypertension must be diagnosed and properly treated independently of age. Of course, always considering vulnerabilities and always considering possible risks. But for most patients, hypertension treatment must be prescribed. First of all, we have to obtain an accurate blood pressure reading, especially because older patients have underdiagnosed hypertension, are usually underdiagnosed for hypertension. We have to use validated automated monitors or calibrated Android devices. The patient must be seated with, uh, with support feet. The patient must be oriented not to talk during the measurement. The arm must be supported at heart level. We have to put a cuff on bare arm always as possible, using correct cuff size. Keep legs uncrossed. This is very important, especially for women. The patient must have an empty bladder and support back to, for an accurate measurement of blood pressure. So, once the patient is diagnosed, we have to treat hypertension. And here are some recommendations on blood pressure threshold for initiation of pharmacological treatment. The WHO recommends initiation of pharmacological antihypertensive treatment of individuals with a confirmed diagnosis of hypertension and systolic blood pressure of 140 or greater, or diastolic blood pressure of 90 millimeters of mercury or greater. This is a strong recommendation. Who also recommends pharmacological antihypertensive treatment of individuals with existing cardiovascular disease and systolic blood pressure of 130 to 139 millimeters of mercury. Here the threshold is lower, and we must remember this. The WHO suggests pharmacological antihypertensive treatment for patients without cardiovascular disease, but with high cardiovascular risk, diabetes, or chronic kidney disease, for patients with systolic blood pressure over 130 millimeters of mercury. So, if a patient have a high cardiovascular risk, the threshold is lower as well. And most older patients have high cardiovascular risks. So we have to pay attention to this. Regarding treatment targets, who recommends a target blood pressure treatment goal of less than 140 and 90 millimeters of mercury in all patients without comorbidities? However, if a patient with hypertension have cardiovascular disease, the treatment goal is lower, is 130. Of course, we have to pay attention to implementation remarks. Suggested tests include serum electrolytes and creatinine, lipid panel, glycated hemoglobin or fasting glucose, urine dipstick, and an electrocardiogram, if available. In low-resourced areas or non-clinical settings where testing may not be possible because of additional costs and lack of access to laboratories and EKG, treatment should not be delayed and testing can be done subsequently or sometimes be put aside. Some medicines, such as long-acting dihydropyridine calcium channel blockers, are more suitable for initiation without testing compared to diuretics and ACE inhibitors, especially because potassium levels must be assessed and creatinine levels as well. But if we don't have access to laboratory testing, even when we don't have access to laboratory testing, this is not an absolute contraindication to prescribe thiazide diuretics and ACE inhibitors, because these two drug classes are very effective on both controlling hypertension and reducing the risk of incident cardiovascular disease. Never forget to guide your patient to reduce salt intake, engage in regular physical activity, maintain a healthy weight. If possible, eat fresh natural food, don't smoke, and follow medical advice. We know we know what lifestyle management advices we have to give, and they are here. But we also know sometimes several barriers imposed during the way and decrease patient adherence. Socioeconomic factors, underlying diseases, old habits, all can mediate difficulties and may interfere with patients' adherence to non-pharmacological treatment. But we have the obligation to put these recommendations always when we diagnose hypertension and diabetes. Here's an analytic framework for antihypertensive medication treatment, but I'll make it simpler. We know we have to start treatment, antihypertensive treatment for patients, including older patients. But when we are recommending treatment for an older patient, again, we have to assess the vulnerability status of each patient. If you are recommending treatment for a vulnerable patient, keep this in mind. Start low, go slow, but go to target. This is a geriatric medicine mantra. Start low and go slow. Start low and go slow. Because this is a way to prevent adverse events, in a way to prevent treatment withdrawal. Because if we start treatment with a regular or a high dose of antihypertensive treatment, an older patient may experience dizziness and other side effects that can influence the decision to withdraw a treatment. So, treatment tips for treating hypertension in older patients. The starting dose should be the lower possible dose. Excuse me. Independently of the treatment choice, start with low dose of hydrochlorothiazide, 12.5 milligrams, half a pill, amlodipine, 5 milligrams, hemipril, 5 milligrams, and go slow. Treatment uptitration must respect at least a 1 month interval between those uptitration. Go from 12.5 to 25 milligrams of hydrochlorothiazide. Go from 5 to 10 milligrams of amlodipine and ramipril after at least 1 month of treatment. But don't forget to go to target. Antihypertensive treatment is not a thing that exists or don't exist. This is not, I'm sorry, dichotomous. This is not a dichotomy. You have to go to target. You have to treat hypertension properly. Decreasing blood pressure levels below 140 and 90 millimeters of mercury at least. But you have to go slowly to this goal. Aim for BP less than 130 for people at high risk, such as individuals with diabetes, coronary artery disease, stroke, or chronic kidney disease. You can go slowly to this target. Most patients will need at least 2 full dose medications to reach a blood pressure goal. And 30%, 25-30% of patients will need 3 medications. So we have to be, we need to be, we have to go with caution, but we have to go. We have to properly treat hypertension. Slowly, but we have to treat. Always monitor for adverse drug reactions. Redirect treatment always when needed. If a patient experiences a side effect, you can lower the dose or change for one of the first line indicated treatments, which are represented here. This is a WHO framework to treat hypertension. Here, step 1, screen all adults, especially before the 30s. Step 2, if hypertension is diagnosed, prescribe a thiazide-like diuretic. Here you can start with a thiazide-like diuretic or an ACE inhibitor or a calcium channel blocker medication. You choose what is best for your patient. And then you have to go to target. Other treatment considerations. If there is a prior heart attack or stroke, statin, you should prescribe statin at the same time. Atorvastatin or simvastatin. If there's a prior heart attack or ischemic stroke, start low-dose aspirin as well. If the patient feels faint on standing, check blood pressure while standing. Look for orthostatic hypertension. Consider reducing the dosage or number of medications used. If a patient is experiencing side effects, we have to act. We have to reduce those. We have to deprescribe medication. Even we know these treatments are effective, we must keep in mind that side effects may decrease quality of life. So it must be considered during monitoring. I'll talk about diabetes and then we can go to the Q&A section. Diabetes is a very prevalent condition as well. It is estimated that 537 million adults are living with diabetes in the world. 3 in 4 adults with diabetes live in low and middle income countries. 6.7 million deaths due to diabetes in 2021. Though these are very impressive numbers. And we know the most important risk factors for type 2 diabetes, which are unhealthy diet, physical inactivity. 1 in 3 diabetic patients is overweight, and 1 in 10 is obese. So this is a major problem that must be properly addressed. Diabetes is diagnosed using some tests, as you know. We must test adults who are 40 plus years old and who are overweight or obese or follow your national guidelines. But if a patient have 40 plus years old, you have to screen diabetes. And for younger patients, younger obese or overweighted patients, diabetes screening is also recommended. Here are diagnostic values according to the HEARTS program. A fast blood sugar levels over 126, or a random plasma glucose over 200, or a plasma glucose 2 hours after 75 gram oral glucose load over 200. Or you can use glycated hemoglobin as a diagnostic test if it is over 6.5%. To prevent complications associated with diabetes, you have to measure blood pressure at every scheduled visit, review medication as per hypertension protocol, refer for dilated pupil retinal exam upon diagnosis if possible, examine feet for ulcers at every visit, refer to higher level of care if ulcer present, assess risk of lower limb amputation annually, especially foot ulcers, sensory neuropathy by monofilament, presence of healed or open ulcers, calluses. It is very important to examine a diabetic patient's feet and limbs. Test for proteinuria annually. Set goals of care. Prevent complications, optimize quality of life. This is a person-centered, outcome-driven treatment framework that is very interesting. We have to consider specific factors that affect choice of treatment, share decision, agree on management plan to increase treatment adherence, implement management plan, monitor and support, and review the management plan at every visit. So here's a framework. Counsel on diet and physical activity, review in 3 months. If goal not achieved, begin metformin, 500 milligrams once daily. Counsel on diet and physical activity and adherence at all visits. Review in 3 months. If goal not achieved, increase dose to 1,000 milligrams once daily. And remember, if you choose to start metformin on higher doses, it may increase the risk of side effects, especially diarrhea, which is the main cause of treatment withdrawal. So again, start low and go slow. If after 3 months in higher dose metformin treatment goal is still not achieved, add glycoside or glimepiride. Counsel on hypoglycemia at all subsequent visits, because this class of medications are associated with hypoglycemia. Review in 3 months. If goal not achieved, increase dose. If still not achieved, despite adherence to medication, healthy diet, and physical activity, refer to higher level healthcare facility or start yourself an insulin prescription. Metformin is the first line therapy for diabetes. So because it's effective, it reduces macro and microvascular outcomes. Metformin reduces glycated hemoglobin by 1 to 2%. It is not associated with weight gain. It usually is well tolerated, especially if it starts low and goes low. It is safe. No hypoglycemia is associated to metformin. It's a low-cost treatment. Remember, start low and go slow. Sulfonylureas, glibenclamide, glycoside are important treatment tools here because you can achieve a quick response on glucose levels, blood glucose levels. It reduces glycated hemoglobin as well. It's a low-cost medication. However, it is associated with weight gain and significant hypoglycemia risk. So prescribe this medication class. However, monitor hypoglycemia events. Use with caution. Start very low, not only low, and go very slow. Start, for an example, glibenclamide, 2.5 milligrams once daily. And after 1 month, 5 milligrams once daily. Only if patient doesn't experience hypoglycemia events, you should then increase dose to 5 milligrams 2 times a day. Or you can use glycoside, which is safe. You can start with a 14 milligrams dose with breakfast and increase it slowly until 30-20 milligrams. Glycoside has a lower risk of hypoglycemia compared to glibenclamide, but it is not always available. Avoid glibenclamide in patients over 60 years if possible. But as I said, if you choose to use glibenclamide, start it very, very low and go very slow. Here are some tips for insulin prescription. Suggested guidelines for beginning dose 0.2 units kilogram a day. For vulnerable patients, 0.1 unit per kilogram per day may be a safer choice. Give 2/3 of this total dose of daily insulin during the day before breakfast, and the other third at bedtime. If you choose to prescribe regular insulin with NPH insulin, prescribe a ratio of regular to NPH insulin of 1:2. And remember, hypoglycemia is a major problem here. Monitoring is indicated, especially when insulin treatment is initiated, at least until you have it under control. Remember, hypoglycemia risk is higher in vulnerable patients, and you have to consider patient contacts and environment. If a patient has cataract or visual impairment, prescribing insulin can be a huge problem if this patient doesn't have support, proper support. So this is a major problem, but we have to treat diabetes properly to avoid micro and macrovascular events. Again, person-centered healthcare. Remember this. You have to check function and abilities, mental health and cognition, disease severity and comorbidities, and the support network and needs of a patient before deciding. Again, here are our fellows here, the robust fellow, the frail fellow, and the frail fellow. We have to check the benefit risk ratio. We have to properly weight this ratio before decide if we'll treat and how we will treat all the patients with diabetes. If a patient is robust, a clinical frailty scale category 1, 2, or 3, the treatment and the treatment goals are the same you use for older or younger adults. You try to reach a glycated hemoglobin less than 7.5% or 7.0%, especially if the patient has diabetes complications. If a patient is pre-frail, maybe an 8.0% treatment target is the best one to pursue. We have to prevent metabolic complications because a pre-frail patient usually has a low expectancy of life expectancy, a lower life expectancy, lower than 10 years. So imposing high intensity treatments usually don't make sense if a patient has life expectancy lower than 10 years. If a patient is frail, the only objective here is to avoid diabetes-related symptoms and metabolic complications. So be very careful, because in this clinical scenario, hypoglycemia may be a huge problem, a greater problem than diabetes itself. So we have to assess vulnerability before choosing the best treatment for our patients, our older patients, and to set treatment goals. And remember, you have to treat these patients, but sometimes the best course of action is watchful waiting and monitoring, especially for frail patients. So remember the geriatric medicine mantra is start low and goes low. Start low and goes low. It will probably help you to deliver a safer care plan for an older person. Please feel free to ask. I'm here to answer if I may.
Once again, I'd request participants who want to ask questions that you must raise your hands.
Okay, let's go on then. Let's talk about dementia.
There's a question. There's a question.
Sorry. I'm so sorry.
Good morning again, Dr. DeMello. Dr. Griffith here. A quick one. I'm thankful for the presentation. I hope that this is being useful for a lot of our doctors out there. But one of my questions I have is the bioinsulin. that is the 30/70 insulin. Would you recommend this use for older patients or not?
I prefer applying prescribing basal insulin without short-acting insulin first as first-line insulin therapy, because you can up-titrate treatment after monitoring the patient. And if you need to add a short-acting insulin, maybe the combined presentation, insulin presentation, may be a safe and useful choice, because you will reduce the number of, I'm sorry, I don't know how to say, needle applications, insulin applications. So the patient can feel comfortable with this approach, but you have to monitor after you decide to use this combined presentation. You can use, yes, it's a possibility. I would say I prefer, as a first-line insulin therapy, the basal insulin without the short-acting insulin, and then, if needed, to associate regular insulin and maybe using a combined presentation. Did I answer your question, Dr. Griffin?
Yes, you did. Thank you so much.
Dr. DeMello, there's another question from Dr. Bhavinash Prasad in the chat box. His question is, for patients who do not tolerate well metformin, what about DPP-4 inhibitors?
That's a very good option, but usually the cost is a problem. But if a patient can afford this class of medication, it is a very good choice. If a patient doesn't tolerate metformin.
I don't think there's further questions at this point.
Okay, let's go on. Very good questions, thank you. Thank you for the opportunity to clarify these points. Let's talk about dementia. Dementia is one of the major causes of disability and dependency among older people. And this is a very prevalent condition, especially in patients over 75 years old. It is estimated that nearly 10 million new cases are diagnosed every year in the world. It means one dementia diagnosed every 3 seconds. So this is huge. Here you can see the estimated age-specific annual incidence of dementia. And the older the patient is, the higher the risk is. In low and middle income countries in Latin America, the risk is still lower than in high income countries, but this scenario is expected to shift in the next 10 years. Dementia will become a very relevant problem in Latin America, especially because we are improving the management of chronic diseases, and people will live longer. And the longer they live, the greater is the risk for dementia. The dementia is the side effect, is an important side effect of living longer. Living longer is a human uh, conquest, but it comes with a side effect, and the side effect is dementia. Dementia is not a normal part of aging. Dementia is a disease. People live for many years after the onset of symptoms of dementia. With appropriate support, many can and should be enabled to continue to engage and contribute within society and have a good quality of life for years with dementia, at least 5-6 years after the onset of symptoms. So we have to be careful to not stigmatize dementia patients. Dementia is overwhelming for the caregivers. I used to say that dementia is a family disease. It's not a single patient disease. Adequate support is required for them for the health, social, financial, and legal systems. But we can do our share here. Sometimes, as we have short time during a consultation, we forget to proper pay attention to the caregiver. But caring for the caregiver sometimes is the best way, is the best treatment course of action to take care for another patient. So considering the caregiver burden is very important when caring for older people. Here is the major criteria for neurocognitive disorders. To diagnose dementia, we must follow the DSM-5 criteria, which is the evidence from the history and a clinical assessment that indicates significant cognitive impairment in at least one of the following cognitive domains. 1, learning and memory. 2, language. 3, complex attention. 4, perceptual motor function. And 5, social cognition. And the impairment must be acquired, not a lifelong cognitive impairment, and must represent a significant decline from a previous level of functioning. The cognitive deficits must interfere with independence in everyday activities, must interfere with the ability to perform activities of daily living. In the case of neurodegenerative dementia, such as Alzheimer's, the disturbances are of insidious onset and are progressive based on evidence from the history or serial mental status examinations. The disturbances are not occurring exclusively during the course of delirium. Delirium means an acute cognitive impairment state, usually caused by a clinical condition or a medication. Here are the neurocognitive domains to be assessed. We have to assess language through object naming, word finding, fluency, grammar and syntax, receptive language, learning and memory, through free recall and cued recall of words, recognition memory, and all this from when we assess all cognitive domains, we have to find impairments in at least 2 of these domains to diagnose dementia. Learning and memory alone are not sufficient to diagnose dementia, especially because memory impairment and memory issues are very prevalent in older patients, and it is mainly caused by depression or anxiety or other mental conditions. Sometimes it is caused by daily burden, how can I say, tiredness and lots of things to do at the same time may impair attention and may cause memory impairment. So memory impairment, isolated memory impairment, is not sufficient to diagnose dementia. The most used tool to assess multi-cognitive domains at the same time is the Minimental state examination. Here we can assess memory, language, executive domains, and much more. So it is a very easy to perform, quick to perform instrument that may be included in all the person's assessments. But you must use this tool only if you have only if dementia is suspected. You should not use the Minimental state examination as a screening tool. As I showed you yesterday, we have more objective tools to screen for cognitive impairment, especially memory recall of words and time space orientation screening questions. Do not use the Minimental as a screening tool. But if you suspect patient has dementia, this is a very useful tool. Again, if you find cognitive impairment after testing, properly testing a patient, remember, dementia will only be diagnosed if you have at least two cognitive domains impairment plus interference on activities of daily living performance. As I showed you yesterday, usually dementia affects the ability to perform instrumental activities of daily living in early stages. So to diagnose dementia, you have to find cognitive impairment and loss of the ability to perform instrumental activities of daily living. The first instrumental activities the first loss of instrumental activities are using transportation, alone, managing finances, managing medication, and then the ability to housekeeping. This is the first instrumental activities of daily living lost when dementia starts. What are the most common symptoms experienced by people with dementia syndromes? The early stage is often overlooked. Relatives and friends and sometimes professionals as well see it as old age. It's normal, it's part of aging, just a normal part of aging process. Because the onset of the disease is gradual, it is difficult to be sure exactly when it begins. The patient becomes forgetful, especially regarding things that just happened, may have some difficulty with communication, such as difficulty in finding words. But as I said, memory issues are very common. So we used to assess memory impairments that can impose difficulties to perform activities of daily living, like forgetting an open window, forgetting an open door, forgetting food in the fire of the while cooking. This is memory issues with red flags. Forget important, forget doctor visits, forget family names, forget where they are, forget dates, especially memory issues associated with space and time disorientation. Patients become lost in familiar places, lose track of time, have difficulty making decisions and handling personal finances, have difficulty carrying out complex household tasks, and may present mood and behavior changes, may become less active and motivated, may show mood changes, including depression or anxiety, may react unusually, angrily, or aggressively on occasion. During the middle stage a patient become very forgetful, especially of recent events and people's names, have difficulty comprehending time, dates, places, and events, may become lost at home as well as in the community he used to easily uh, walk in, have increasing difficulty with communication, speech, comprehension, usually use uh, um, communication, uh, repeated speeches and some patterns of speeches. Need help with personal care. During this phase, loses patients lose the ability to perform basic activities of daily living. They will start to need support to perform self-care activities like bathing and toileting. During the late stage, patient is usually unaware of time and place, have difficulty understanding what's happening, presents with behavioral changes may escalate and include aggression towards carer, nonverbal agitation like kicking, hitting, screaming, or moaning, and usually is unable to find his or her way around in the home. Dementia is a syndromic diagnosis, and under the dementia umbrella, we have uh, several possible differentials as Alzheimer's, vascular dementia, Lewy body dementia, and others. So to distinguish these differentials is sometimes hard, especially in during the early stages of the disease of dementia. So here we have some tips to distinguish between differentials, but it is less important than the syndromic diagnosis because treatment usually don't change depending on the differential diagnosis. Here is a WHO framework for dementia. Assess for signs of dementia. Are there problems with memory and orientation, as I told you before? If yes, does the person have difficulties in performing key roles, activities of daily living? If yes, are there any other explanation for the symptoms? Here is an important topic because delirium must be the cause, and maybe other clinical conditions like hypothyroidism and vitamin deficiency and other infectious disease like syphilis or HIV. So if the symptoms are not possibly explained by other clinical conditions, we have to go further and understand, does the person have moderate to severe depression? Mental diseases may present with cognitive impairment. If a patient has severe depression, you have to manage depression before establishing a dementia diagnosis. If the patient doesn't have depression or other psychiatry disorder, then you have to suspect dementia. Here are some clinical conditions that may explain cognitive impairment. So some tests are indicated while assessing a patient with suspected dementia. Severe anemia can explain cognitive impairment in vulnerable patients. Electrolyte disturbances like hypo and hyponatremia, uremia, hypercalcemia, liver cirrhosis, especially severe liver function deterioration, and vitamin deficiencies like the B12 deficiency may present with cognitive impairment. And most commonly, hypothyroidism or even hyperthyroidism may present with cognitive impairment in vulnerable patients. We have to test thyroid function, and we have to test for HIV as well. Images are indicated as to exclude some differentials, especially brain tumors or previous Lachner stroke, but usually it is not helpful during the diagnostic process. So if you have access to a brain image, you will ask this exam just to rule out some other conditions, not to confirm Alzheimer's disease. The most common etiology for dementia is Alzheimer's disease, especially in women. But in men, this is an important differential, especially in older men over 75 years old. But vascular dementia is very important, especially in younger adults and older persons between 60 to 70 years old. And how to manage dementia. Here are some protocols presented by the WHO Intervention Guide for Mental, Neurological, and Substance Use in non-specialized health settings. Protocol 1. If you diagnose dementia without behavioral and or psychological symptoms, the main course of action is provide psychoeducation to person and carers to explain what is happening and what is to come. This is the most important conduct here. Encourage carers to conduct interventions to improve cognitive function. That is, physical activity, cognitive stimulation, and social participation. It is very important to decrease the pace of dementia. Promote independence, functioning, and mobility, if needed, under a care of a caregiver. but promoting independence and functioning is very important. Provide carers with support. As I said before, this is more important than pharmacological treatment. You will consider medications only in settings where specific diagnosis of Alzheimer's disease can be made and where adequate support and supervision by specialists and monitoring for side effects from carriers is available. Because specific medication for Alzheimer's disease may cause more harm than benefit, especially because yet there are evidence of treatment effectiveness. The clinical impact of these treatments are very small. So usually you can prescribe a treatment trial, but you have to monitor this patient for side effects. If any side effect occur, deprescribing is an option. You have to think and stop in the medication. Protocol 2, dementia with behavioral and psychological symptoms. Protocol 1 plus manage behavior and psychological symptoms. There are several behavioral and psychological symptoms control toolkits for caregivers. You can easily find it in the internet, and you can provide this guidance for caregivers. Non-pharmacological actions are much more efficient than antipsychotic medications to treat behavioral and psychological symptoms. Yet, if there is imminent risk to the person or carer, you can consider an antipsychotic medications if symptoms persist or if there is imminent risk of harm or suffering. And if possible, if it is happening, refer to specialists when available. Here we have some guidance for pharmacological intervention. You can find it in the WHO documents available. But what is most important here, do not consider cholinesterase inhibitors or Minimental routinely for all cases of dementia. It is not effective for vascular dementia and all the differential diagnosis for dementia. Consider medications only in settings where specific diagnosis of Alzheimer's disease can be made and where adequate support and supervision by specialists or a primary care provider are possible. Antipsychotic medication for behavioral and psychological symptoms provides psychosocial interventions first. Avoid benzodiazepines always as possible. Avoid IV haloperidol. I used to say avoid any IV antipsychotic medication for patients experiencing behavioral symptoms. Prefer subcutaneous medications or intramuscular medications. Always follow the principles of start low, goes low. It is useful for different clinical scenarios. Use the lowest effective dose. If you prescribe an antipsychotic medication, use the low dose. Start with the lowest dose possible. And if the patient responds to this low dose, do not increase the dose. Monitoring extrapyramidal symptoms are very important, especially muscle stiffness and rigidity. So the most common diagnosis here is Alzheimer's disease. And remember, to diagnose dementia, you have to find an association between cognitive impairment and loss of functional ability. If dementia is diagnosed, the main course of action is to educate and to provide information regarding the disease and its progression. And when psychological and behavioral symptoms are present, give guidance, give caregivers guidance on non-pharmacological interventions to control the symptoms. Okay? Briefly, that's it. So if you have any questions, feel free to ask. Okay, so let's go on. This is the last section. This is the last presentation section. I want to talk to you about falls and fracture risk. Falls are considered a major geriatric outcome, a geriatric syndrome. It is one of the giants of geriatrics, one of the big eyes from instability. Falls are associated not only with fractures and direct injuries, but it is also associated with a syndrome called fear of falling, and with a vicious circle. This vicious circle here, these are two WHO pivotal documents regarding falls prevention and management that you can easily find in the internet as well. As I was saying, falls are considered a major geriatric harm, and it is a vicious circle. A fall may cause fear of falling. A fall may cause decreased physical activity because of fear of falling. Decreased physical activity is associated to musculoskeletal decrements. Yeah, meaning sarcopenia, muscle mass loss. That imposes a greater his risk for gait instability and higher risk of falls. So this is a vicious circle that must be broken. This figure here, this chart, shows us fatal falls rates by sex and age group in the United States. The older the person, the greater the risk of dying because of fall episode, as you can see here. As I showed you before, in Guyana, it is not different. In the red arrow here, you can observe the percentage of annual deaths caused by a fall episode for adults aged 50 to 69 years. Here represented in this green box. And the risk increases with age, as you can see here and can see here, for older adults aged 8 years older or older. This is a major problem that must be addressed. Falls are caused by a multi-direction risk factors model based on intrinsic and extrinsic components, as you can see here. Falls are dependent on behavioral risk factors like multiple medication use, inappropriate footwear, excess alcohol intake, and lack of exercise, as biological risk factors like age, gender, and race, but especially can be caused, or the risk of falls may be increased secondary to chronic illnesses like Parkinson's disease, arthritis, osteoporosis, physical, cognitive, and affective capacities decline. And it can be modulated by socioeconomic risk factors like inadequate housing, lack of social interactions, lack of community resources and support, low income and education levels, and environmental risk factors like poor building design, cracked or uneven sidewalks, slippery floors and stairs, insufficient lighting, those rugs. And it is important to say that older people usually fall inside their homes. It's counterintuitive, but that's what happens. Older people usually fall inside their own home or in residential care facilities. As I said, intrinsic and extrinsic risk factors interacts with precipitating causes like trips and sleeps, drop attacks, syncope, or dizziness to be translated into a fall episode, as I can say, if I can say it like this. So we have to systematically address this problem when assessing an older person. We have to check falls history and ask any falls in the last year. Ask about context of this fall. Consider potential causes and consequences to guide patient or control chronic conditions that can cause a fall episode, a new fall episode. Seek for red flags, fainting, loss of consciousness, dizziness. Assess gait and balance. Assess postural hypertension if a patient refers a fall. Review medication. Medication review is very important. Taking any meds to help you sleep or lift your mood. So sleeping pills are the enemy here. They are associated with increased risk of falls, especially during the night, especially if a patient already has mobility impairment or visual impairment. So medication review is an important part of our work to prevent falls. Here are an easy home modifications. Easy home modifications to prevent falls. Some tips that we can deliver for patients or caregivers. Oh, sorry. And here are interventions to prevent falls. Strongly recommended gait, balance, and functional training. Nothing is more effective to prevent falls than physical exercise, physical activity. And with it, we have to perform home assessment and modifications, particularly for high-risk groups, including reducing trip hazards and improving lighting. We have to reduce or withdraw psychotropic drugs. We have to prescribe multifactorial intervention as exercise, medication review, and so on. Now let's talk about fall fractures. Fractures are a very important disease to be prevented in older adults because it has several consequences. Usually, a fall with fracture, especially femur fracture, is the start of the end, is the starting point of several years of low quality of life. An older adult falls every second of every day in the world. 1 in 4 older adults reported a fall. And falls are the first cause of hip fractures. So these two problems are interconnected. We have to address falls risk in order to avoid fractures, because fractures add morbidity and dependence, as we can see here. if a person do not experience a fracture during their life course, increased morbidity and dependence due to aging alone is represented here. However, if a Colles fracture, a wrist fracture occurs, this is the added morbidity that are imposed for some time. A vertebral fracture may impose and add morbidity that can become permanent, and a hip fracture is the worst case scenario. But something I want to share with you. We usually think about fracture associated with osteoporosis. But as you can see here, most fractures occurs in patients without osteoporosis. Here you can see the prevalence of osteoporosis in patients presenting with different types of bone fractures: lumbar spine fracture, hip total fracture, and hip femoral neck fracture. Yes, the prevalence of osteoporosis is higher among fracture patients when compared to a control group. Here is the prevalence of osteoporosis in patients with total hip fracture. And here is the prevalence of osteoporosis and low bone density in patients without a fracture. Yes, osteoporosis is a risk factor for fracture. There's no doubt about it. However, it is also possible to confirm that most fractured patients do not have osteoporosis, as you can see here. In patients with hip total fracture, almost 70% of patients don't have osteoporosis. For lumbar spine fracture, more than 70% of patients don't have osteoporosis. Almost 40% of patients have normal bone mineral density assessed by densitometry. For hip femoral neck fracture, more than half of patients don't have osteoporosis. That is why we have to assess the overall risk for a fragility fracture, because treatment decision will be based on it, not in the presence or absence of osteoporosis. This is why today we in geriatrics, we prefer to call fragility fracture instead of osteoporotic fracture, because most fractured patients don't have osteoporosis, and fractured patients, even in the absence of osteoporosis, have to be treated accordingly. Fragility fracture is defined as a fracture occurring spontaneously or following minor trauma, such as a fall from standing height or less. This is what was previously called osteoporotic fracture. I prefer calling it fragility fracture because most patients, fractured patients, don't have osteoporosis. And why this is important? Because there are other important or even most important risk factors for fracture in older people than osteoporosis alone. Fracture risk assessment must be assessed in women aged less than 65 years and men aged less than 75 years if risk factors are present. These include previous fragility fracture. Previous fragility fracture is the greater risk factor for a future fracture. So if a patient already had a fracture, he or she is considered a high risk patient and must receive treatment accordingly. As we will see in the next slide. Current use or frequent recent use of oral or systemic glucocorticoids are a major risk factor for fractures. History of falls are an important risk factor for falls, as are family history of hip fracture or fragility fracture. Of course, low body mass index and low bone mineral density are important risk factors for fracture. Yet, we have important information that can be assessed during a primary health care medical consultation. And in most cases, these informations, these variables, are sufficient to support a treatment decision. In most cases, we do not need a bone densitometry to decide if a patient needs to be treated. So, with that in mind, the WHO proposed a fracture risk assessment tool called FRAX, and you can access in the internet. It gives a 10-year probability of fracture in untreated patients. That is based on age, gender, weight, height, clinical risk factors, as I just said, previous fragility fracture, parental history of hip fracture, current smoking, glucocorticoid treatment, rheumatoid arthritis, and diabetes. Now, diabetes was included as a clinical risk factor. If a patient has diabetes, you can click in the rheumatoid arthritis item and choose yes. This is rheumatoid arthritis and diabetes are equivalent risk factors for fractures. So here are the FRAX. This is the FRAX layout. You can select the country. I advise you to choose an Latin America country, as we don't have a specific Guyana database. And then you will insert all this information here, showing you that you don't need to fill this item here if you don't have a bone densitometry. Usually, as I said, you don't need a bone densitometry to decide. Here, I put this information. Woman, aged 75 years, with this weight and height, no previous fracture, no parent fractured hip, current smoking, not using glucocorticoids, and not having rheumatoid arthritis, nor secondary osteoporosis or alcohol abuse. This is the 10-year probability of fracture. That is 9.4% for a major osteoporotic fracture, and 5.8% risk for hip fracture. Cutoff for treatment prescription based on FRAX is 3% for hip fracture and 20% for major osteoporotic fracture. So, based on the FRAX results, here is the treatment framework. Again, let me get back here. As you can see here, based on the simple clinical information, I learned that my patients risk 10-year probability of fracture, hip fracture, is 5.8%. So I don't need any other information to classify, to categorize this patient as a high-risk patient. So in this example, this old lady must optimize calcium and vitamin D status using diet, through diet, proper sun exposure, or to treatment of vitamin D deficiency if you suspect or confirmed it. This patient should be advised to exercise and to adopt falls prevention strategies. And even she never had a previous fracture or or even that she doesn't have a densitometry test, a bone densitometry test, you must consider oral bisphosphonate or other inhibitor of bone resorption. That's what I'm trying to show. If a patient is categorized as low risk, you will give guidance on proper diet and exercise. It doesn't change, but you don't have enough data to support the prescription of a specific medication. Sometimes when a patient is categorized as having low risk for fracture, especially intermediate risk for fracture, in this case, a bone densitometry may make the difference between not prescribing or prescribing a medication. But for patients with very high risk or low risk of fracture, a bone densitometry is not necessary. Okay? So we have to think about falls prevention, and we have to think about fracture risk when assessing an older person, because as we saw, a fall or a fracture may impose important morbidity and will lower the quality of life of an old person. So it must be included in the primary, this scenario of assessment must be included in the primary healthcare setting. And that's all for the day. I'm here to answer some questions about this specific section, or if you have questions regarding the previous sections as well.
There is a question from Dr. Maloney. Dr. Maloney, would you like to share your question, or do you want me to read it? I will just unmute you quickly. You can talk now, Dr. Maloney. You just need to unmute your mic.
Okay, good day. I listened to the series of lectures. I found them very informative. Here in Guyana, we have a main national park that is utilized a lot during the good weather. And then the seawalls where people engage in physical activities such as running, walking. What I'm wondering, what role would PAHO play in, I don't know what's going on in our other neighboring countries, but what role would PAHO play, seeing we have this reality now of our senior citizens being with us for some time now, and they will be integrated into care management and these lists of complications and comorbidities that we need to look out for. Prevention is really the key, seem to be the key that we should be driving at. And I'm asking the question, what role would PAHO play, if there is such a role, in asking governments to ensure facilities such as parks and so on be made available for senior citizens to be given some form of physical activity, because we know most of the time they're locked up their home. They're probably with grandkids while the adults are out working. So maybe some way, some sort of infrastructure accommodation can be put in place, not only for citizens when they would have aged, but even our current population, which will grow old, to engage in more physical activity to halt, if not prevent, these chronic non-communicable diseases and the complications that can ensue.
Thank you for your comment, very important comment, and for your question. Yes, recommending public spaces that allow people to not only exercise, but socially that can improve social interactions is of course something that PAHO and the WHO recommends, but we know sometimes it is hard to implement, especially in big cities and where the urban infrastructure are already established. But it is important to think about public spaces that allow not only older people, but the whole population to exercise and to enjoy the presence of others. I don't know if I properly answered your question, but yes, I think this is a concern. This is a recommendation, but we know sometimes it's very difficult to implement.
Okay, thank you.
Dr. Baldio James has a question. Dr. James, please unmute your mic and then you can speak. Dr. James, please unmute your mic. Dr. James, go ahead and ask your question, but you need to unmute your mic. I don't. Okay, any other question? Does anybody else have a question? Dr. Mahathir or Dr. Griffith, would you like to share a few words or something at the conclusion of this lecture?
Hey, Doc. Good morning.
Good morning.
First of all, let me say thanks to PAHO and thanks to Doc for facilitating, for having these lectures with us. I think it is basically a second step after Dr. DeHart would have done some lectures, but I think it is really, really important for us to continue and even look further to see if we could provide some longer term training for those who might be interested. Because I guess our population now maybe over 10% is already over 60. And I'm sure a lot of persons would have found that we would have learned new things based on these lectures. So let me say thanks to Danielle, thanks to yourself, Doc, thanks to our lecturer for taking on the challenge of doing these lectures. I'm also hoping that we could have these lectures online for anyone who might want to go back and check them, or for anyone who might have missed these lectures and would like to learn from them, because they've been very informative. So from me, on behalf of the Ministry of Health, thanks a lot. And I hope those who would have been part of the lectures and those who would listen to it in the future, that we could all put it in practice for the benefit of our Guyanese population. Thank you.
Thank you, Dr. Mahadev. We are planning to have a training of trainers lecture session with Dr. DeMello quite soon, and maybe in early October. So we'll hopefully take it on from there. And Dr. Griffith, do you want to share something at this point?
Good afternoon, everyone, again. Thank you, Dr. DeMello, for the whole activity you did. We are grateful from the ministry. What is it we are focusing on is that we saw the need that how the management of elderly care needs to be improved. So that's why we are collaborating with PAHO to ensure that this activity would be a success and at least give the doctors and maybe the medics at least some awareness on how to manage elderly care, because we know that one of the biggest thing is the chronic disease. The care is not being done properly for elderly, and it's something that we need to improve, and the ministry is working hard to do so. We've been implementing some different packages as like the hearts and so some was mentioned in this activity. So I'm grateful at least a wide range of doctors were able to at least hear how to treat this. And as mentioned by Dr. Mahadev, we do wish to have the presentation to share with them, because some doctors already reached out to me since I'm organizing this, indicating that they would like to have the presentation because it was so informative. So I'm grateful for this activity. Thank you again, Doc DeMello, for this activity.
Thank you, Dr. Griffith and Dr. Mahadev, for your words. And, I also want to thank Dr. DeMello for taking this weekend to present this very, very informative lecture. And we will make arrangements to share the presentation with the ministry so that it can be distributed to those who wish to listen. So let me just thank Dr. DeMello once again for all these efforts, and he will continue to work with he's part of our collaboration with the ministry to improve elderly health. We no longer call them elderly these days, we call them older people. So, his efforts have been very, very useful, and we hope that in next month, actually in October, we probably have a training of trainers session, and then there'll be more training for health staff. These are some of the plans that we currently have. So before I close, if Dr. DeMello wants to say anything, that's okay. Otherwise, do you have anything more to say, Dr. DeMello?
Yes, Dr. Anand, thank you very much for the opportunity to share this lecture with you all. And I would like to thank the Ministry of Health for the opportunity to collaborate with you and PAHO. And thank you for your attention. I hope it was useful to you. And I'm at your best disposal, and don't hesitate to call me again if you think it's appropriate. Thank you very much.
All right, so we are at the end of this session. Thank you all for attending, and thank Dr. DeMello once again for this presentation. Thank you.